This presentation is going to review Chapter 10 of the Torres Patient Care Book, Tubes, Lines, and Other Devices. At the end of this presentation and after reviewing Chapter 10, students will be able to define nasogastric and nasointestinal tubes and the radiographer's responsibility regarding them, describe all considerations for patients with central venous catheters, outline the steps in the operation and maintenance of suction equipment, explain the precautions necessary when working with a patient who has a tracheostomy, define precautions taken for patients with a chest tube, explain care considerations for patients with tissue drain, describe precautions to be taken with patients undergoing retrograde pyelography or placement of a ureteral stent, and identify specific types of tubes, lines, catheters, and devices seen on radiographic images. Nasogastric, abbreviated NG, and nasoenteric, abbreviated NE, are tubes that are used for both treatment and diagnosis. These tubes have a channel that allows for the removal of secretions and air or the delivery of medications, nutrients, and diagnostic agents. Radiographers need to handle and move patients with these tubes carefully and understand how to manage gastric suction as needed based on the doctor's order to avoid harming the patient. Abdominal imaging may be necessary before, during, or after placement of an NG or an NE tube, and this imaging can be done in the department or with the use of a portable mobile X-ray machine at the patient's bedside. Although radiographers don't insert these tubes, they should know how to prepare the patient if the insertion happens in the imaging department and understand what equipment is used. Sometimes patients might have a gastrostomy tube, which is used for those who are very weak and cannot eat normally. These patients require careful and sensitive handling. In some cases, a patient who has vomited or has fluids in their mouth or throat may need suctioning while under the care of a technologist. While the technologist doesn't perform the suctioning, they must quickly assess the patient to ensure the procedure is done promptly to avoid fluid entering the lungs, resulting in breathing problems as well as aspiration. Chest tubes are used after surgeries, injuries, or lung disease to drain fluid or air from the pleural space. If air or fluid builds up and isn't drained, it can cause tension pneumothorax, which is a serious condition that needs immediate attention. After surgery, various types of patients may also have drains that will be placed to manage fluid accumulation. Radiographers should be able to identify these drains and handle a patient with care to prevent them from becoming dislodged during imaging. A nasogastric tube, or NG tube, is typically made of polyurethane, silicone, or rubber. They are inserted through the nose and go down into the stomach, the duodenum, or jejunum. If a patient cannot use their nose for the tube, it can be inserted through the mouth and guided over the tongue. NG tubes serve various purposes, including diagnostic tests, delivering feeding or medications, treating intestinal blockages, as well as controlling bleeding. The most commonly used NG tubes are the Levin and Salem sump types. The two most common types of NG tubes are the Levin and the Salem sump tubes. The Levin tube has a single lumen with holes near its tip, identified on this slide, and the Salem sump tube is a double lumen tube that is radiopaque. It has a blue extension at the proximal end called a pigtail, which remains open to the air. This design allows atmospheric air to flow into the stomach, which helps regulate suction pressure and prevent damage or ulcers in the stomach lining. This image on the slide is showing the placement of a Levin NG tube in the stomach of a patient. Oftentimes, X-rays are performed to ensure that tube placement is accurate within the patient. Other types of NG tubes include the Nutraflex, Moss, the Sengstaken, Blakemore, or the SB, esophageal NG tubes. The Nutraflex tube is mainly used for feeding, and it has a weighted tip and lubricant that activates with gastric secretions to aid in insertion. The Moss tube is a more complex triple lumen tube. One lumen has an inflatable balloon to keep the tube in place within the stomach, and another is for fluid aspiration, and the third is for feeding into the duodenum, as shown on this image. The Sengstaken-Blakemore tube, SB tube, is also a triple lumen tube with two balloons, and these balloons are inflated to apply pressure to bleeding esophageal varices. The third lumen is used for washing out the stomach and monitoring for bleeding. Balloon pressure must be kept constant, but if a patient has difficulty breathing, the balloon pressure must be quickly reduced by cutting the balloon lumens. For safety, an SB tube patient should have a nurse present if they are in the imaging department for a long time. This is crucial to avoid risks of asphyxiation or aspiration or stomach contents into the lungs. Patients with an SB tube are typically cared for within the ICU and portable imaging is performed. Nasoenteric and nasointestinal tubes are very similar to that of NG tubes, except their placement is going to be different. NG tubes are placed in the stomach, and nasointestinal and nasoenteric tubes are placed further into the small intestines or duodenum. Their insertion is very similar to that of an NG tube, and they are used for decompression, diagnosis, as well as treatment. Some common types of NE tubes include the Cantor tube, which is a long tube with a small mercury-filled bag at the end and has drainage holes for aspiration, and it can relieve obstructions within the small bowel. The Harris tube, which is a mercury-weighted tube that moves through the digestive tract by gravity. Gastric and intestinal decompression is its main usage. The Miller-Abbott tube is a long, small caliber catheter with a perforated metal tip and a collapsible balloon, and it is radiopaque. This is also used for decompression of the gastrointestinal tract. Typically, a registered nurse will insert an NG or an NE tube, sometimes a physician as well. Since tube insertion can be uncomfortable and distressing for the patient, especially if they are very ill, it's important for the procedure to be explained to them beforehand. And if the patient focuses on swallowing and breathing during the insertion, the process will be a lot smoother and quicker. Patients should be positioned in a semi-Fowler's position during the tube insertion process with their head and shoulders supported by a pillow. Before insertion, the distal end of the tube is lubricated with a water-soluble lubricant, and the patient is then instructed to swallow as the tube is gently being passed through. It should move down easily with minimal force. Once the tube is thought to be in the stomach, an initial radiographic image is taken to confirm its placement. Once it's confirmed that the tube is in the correct location, the patient should be made comfortable and be informed that the tube is in place. NG tubes are taped securely to prevent accidental withdrawal, whereas NE tubes are not taped as their placement relies on natural peristalsis action. The Levin tube, a type of NG tube, is taped to ensure it remains in place. Care should be taken to avoid pulling out the tube, and it should never be necessary to reinsert it due to careless handling. Patients with NG or NE tubes should not eat or drink anything unless specifically instructed by a physician. So it's very important as radiographers, if we are imaging these patients in the department, that we don't offer them a drink because they should be NPO, which means nothing to eat or drink. And if there is a risk of the patient accidentally removing their NG tube, patients may also be provided with wrist immobilizers to prevent them from pulling it out. If you take a look at both of these radiographs, the first radiograph, labeled radiograph A, is a chest radiograph showing tube placement in its entirety. The NG tube sits just on the left-hand side of the esophagus, as you can see, and the end of the tube extends just at the opening of where the esophagus meets the stomach. Chest radiograph B shows the tube that is further advanced into the stomach on this patient. So the tube goes down into the stomach and is starting to loop around. I wouldn't necessarily say both are chest radiograph B is an inaccurate placement, but if NG tubes are placed too far into the stomach, they are at risk for complications. including migration, coiling, or damage to the duodenum. NE tubes look just like NG tubes and should be put in by a nurse or a physician. Radiographers may assist in tube placement if the need arises. However, NE tubes are not taped. This allows the tube to continue its passage from the stomach into the small bowel. This is why it's called an enteric or intestinal tube. This image shows a Cantor tube within the small bowel that is obstructed. Before administering medication, food, water, or contrast agents through an NG or an NE tube, its correct placement must be confirmed using X-ray. Failure to verify the tube's position could result in administering substances into the pleural cavity, which can lead to serious complications. Initially, the placement of an NG or NE tube can be checked with an image, plain film X-ray, or a fluoroscopy. However, it's not practical to use radiographs every time tube placement needs to be verified. Instead, placement can be confirmed by aspiring stomach or bowel contents through the tube with a syringe and testing the aspirated substances with litmus paper to check for its acidity. If there is any uncertainty about the tube's position, do not administer anything through it. If administration has already started and there is a concern about the tube placement, stop immediately. And if the patient begins to regurgitate, seek help immediately and be prepared to assist with suctioning. To minimize the risk of aspiration, keep the patient in a semi-Fowler position during and after the administration of any substances through the tube. The Levin tube, Salem sump, and other tubes positioned within the stomach can be removed relatively easy. However, it is crucial not to assume that the tubes can be removed just because an imaging examination is complete. The tube should only be removed if specifically ordered by a physician. NE tubes should never be removed by anyone other than a physician or a registered nurse. They may either be removed through the intestinal tract or by pulling them out rectally. While technologists are not responsible for removing NG or NE tubes, they should always be aware of the necessary equipment and procedures in case they need to assist with the process. Suction is the process of removing fluids or debris from an airway or body cavity using a negative pressure. Suctioning should be performed by a physician or a registered nurse. As radiographers, we are not trained to handle suction equipment. Certain conditions may make suctioning risky, such as head or facial injuries, bleeding, esophageal varices, nasal deformities, and severe respiratory conditions. Radiographers should identify when suctioning is needed, alert the appropriate medical staff, and assist with the procedure if required. They are also responsible for daily checks of emergency suctioning equipment within the department to ensure it's functional and stocked with necessary supplies. Signs that a patient may need suctioning include severe vomiting, audible rattling or gurgling, difficulty breathing, and heavy bleeding from facial injuries with an obstructed airway. For pediatric patients, suctioning differs from adults due to their small airways and more delicate tissues. They require a catheter with a smaller tip, and suctioning must be done carefully to avoid tissue damage and rapid onset of hypoxia. Adults may need suctioning through a tracheostomy tube, which is covered in the next section. NG and NE tubes are used before or after digestive system surgeries, and they may be connected to either portable or central suction systems, operating continuously or intermittently based on the patient's needs. When transferring a patient with ongoing gastric suctions, always verify with the physician's orders. If suction needs to be paused, know how long it can safely be interrupted. Ensure that suction can be reestablished quickly, either by using a portable suction machine or the department suction equipment, and be aware of the correct suction pressure, which is typically 25 millimeters of mercury for adults. Exceeding this pressure can harm the gastric lining. For double lumen NG tubes, never use a hemostat or a regular clamp. as this can cause the lumens to stick together, affecting their function. To prevent leakage from a double lumen tube, use a syringe barrel inserted into the suction drainage lumen, the blue pigtail, and pin it to the patient's gown with the barrel pointing up to avoid reflux. The image on the left of this slide is an example of a central suction system. This is what you will have to check within the department and should be in some of the exam rooms. The image on the right is an example of a portable suction system that can be transported with the patient. A gastrostomy involves surgically creating an opening into the stomach through which a tube is placed from the stomach to the outside of the abdominal wall. This tube allows for feeding patients who cannot eat by mouth, and it can be used temporarily or permanently. The tube is secure either by sutures or a crossbar that keeps it in place against the stomach wall. After their gastrostomy tube is placed, the patient will have a fresh surgical incision and a dressing in place. For older gastrostomy tubes, a dressing may or may not be used. After the feeding, the tube is closed with a clamp or a plug in an adapter to prevent leakage of stomach contents, and then coiled and secured with tape or a small dressing. When caring for a patient with a gastrostomy tube, radiographers should be aware of infection risks. If the area around the tube is not fully healed, sterile gloves should be used to prevent infection. It's also important to approach patients with gastrostomy tubes with sensitivity. They might be dealing with changes in the body, image, or chronic illness. Communicate thoughtfully and allow patients to guide their own care as much as possible. This X-ray image shows what a gastrostomy tube looks like. As you can see, it is connected into the stomach, and the diagram shows you exactly how it goes through the different layers of skin to enter the stomach through the abdominal cavity. An endotracheal tube, called an ET tube, contains a radiopaque strip for visibility on X-ray images. The tube is inserted through the mouth into the trachea to establish and maintain an airway for patients who cannot breathe independently. The ET tube should be positioned 5 to 6 centimeters above the trachea bifurcation, called the carina. A chest X-ray is essential after insertion to confirm correct placement. Up to 20% of ET tubes may need repositioned after the initial insertion and can easily shift. An improperly positioned tube can enter the right bronchus, potentially collapsing the left lung, or be too high, leading to air in the stomach. If the tube enters the right bronchus, it can block the air from reaching the left lung, causing it to collapse or become ventilated inadequately. This condition is known as atelectasis. The right lung receives the airflow intended for both lungs, leading to reduced oxygenation and ventilation of the left lung, potentially causing a worsening respiratory disease. If positioned too high in the trachea, air could enter the stomach, leading to regurgitation. Daily X-rays might need to be required to ensure ET tube placement has not shifted due to patient moving, coughing, or ventilator tubing weight. Despite the necessity, ET tubes are linked to complications such as ventilator-associated pneumonia. As you can see here, image A is demonstrating the collapsing of the left lung due to improper ET tube placement. The ET tube is in the right lung, in the right bronchus, which is causing the left lung to collapse. That's why the left side of the chest is all white and gray, and the lungs are not full of air since it has collapsed. Image B is an image showing the left lung has reinflated after the ET tube was withdrawn, and the tip being above the carina, which caused the inflation of the left lung properly. A tracheostomy is a surgical procedure that creates an opening in the trachea to help with breathing. This procedure can be temporary or permanent. It is often performed on patients who have experienced trauma, paralysis, unconsciousness, or respiratory disease. Constant suctioning due to secretion buildup is necessary to maintain patency of the tracheostomy. Patients with newly inserted tracheostomy tubes are very fearful. Prior to imaging a patient with a tracheostomy, the radiographer should speak with the patient's nurse for any special considerations. The radiographer must take special care when moving the patient to avoid dislodgement. The straps around the patient's neck should never be untied that hold the tube in place, and they prevent it from becoming dislodged. In an emergency, an ambu bag may be used to provide breaths by attaching it to the tracheostomy tube. AMBU stands for Artificial Manual Breathing Unit. The blue cap gets removed from the AMBU bag. Rotate the mask away and gently attach the bag to the tube to ensure it stays on during its use. Tracheostomy tubes come in different types and are typically made of plastic or metal. Most tracheostomy tubes have an inner cannula that locks in place. A cannula is a tube used to allow fluids, gases, and other substances into or out of the body. The tube is secured at the back of the neck with ties or tape. For infants or small children, tracheostomy tubes generally do not have a cuff because the tube fits securely without it. There are two different types, a fenestrated tube or a double cuff tube. A fenestrated tube has an opening above the cuff that allows air to flow over the vocal cords, enabling some voice production. A double cuff tube features two low-pressure cuffs that prevent air and stomach contents from entering the trachea while reducing irritation compared to a single high-pressure cuff. In the ICU, radiographers often need to take x-rays of patients on mechanical ventilators. Since these machines are crucial for breathing, it's important to follow all safety measures when handling them. Mechanical ventilators might be needed due to a condition that affects the nerves or muscles involved with breathing, known as extrapulmonary disorders. Alternatively, issues with gas exchange like pulmonary embolism or respiratory distress syndrome can also necessitate mechanical ventilation. Mechanical ventilators fall into two main types, negative pressure and positive pressure. Positive pressure ventilators are more commonly used. These ventilators work by pushing air into the lungs until a set pressure is reached, then letting the lungs deflate naturally. They require an artificial airway, like an ET tube or a tracheostomy tube. You always want to consult with a nurse before starting an imaging procedure on a patient that is connected to a positive pressure ventilator. Some precautions to follow include getting help to move the patient safely, avoiding pulling on intravenous lines or ventilator tubing, keeping the ET tube or tracheostomy tube in place, do not unplug the ventilator, don't disconnect the spirometer, and if the patient appears agitated or confused, stop and inform the nurse immediately. You want to use strict hygiene practice and gloves if there's a risk of contact with blood or body fluids. If there's a problem with the ventilator, an alarm will sound. This could signal a serious issue that needs urgent attention. Patients on positive pressure ventilators can't communicate well because of the ET tube or tracheostomy. In order to help reduce frustration, explain what will happen and provide a way for them to give you written feedback. A negative pressure ventilation is less common. This type of device surrounds the chest with lower pressure to draw air into the lungs. The main difference is in how each method supports or replaces a patient's natural breathing. Normally, the pressure in the pleural cavity is lower than atmospheric pressure. If the pressure changes due to disease or injury, it can lead to problems. A pneumothorax occurs when air enters the pleural cavity, causing the lung to collapse. A hemothorax is when blood collects in the pleural cavity, preventing normal lung expansion, while pleural effusion is when fluid other than blood builds up. All these conditions hinder the lung's ability to expand and get enough oxygen. To address these issues, a tracheotomy, a surgical procedure that opens the chest cavity, is done to diagnose and treat lung and pleural conditions. During this procedure, one or more chest tubes are inserted into the pleural cavity and connected to a water-sealed drainage unit. This setup removes excessive air or fluid, restoring proper pressure and allowing the lungs to expand fully. A water-sealed drainage system is set up by connecting the chest tube to a clear tube that extends in a chamber with sterile water or saline. The chest tube must always stay below the level of the chest to maintain the seal. This is especially important when transporting patients. During inhalation, air and fluid from the pleural cavity are drawn into the drainage tube and collected in the chamber. Because the fluid in the chamber is heavier than the air, it prevents the fluid from being pulled back into the tube and stops outside air from entering. The image on the left shows a large pneumothorax to the left lung. The image on the right shows a chest tube that has been inserted into the pleural cavity to suck the air out so that the lung can re-expand. This diagram is a representation of a water-sealed drainage system that is established by connecting a chest tube to a clear tube that extends in a chamber containing sterile water. The tube leading from the chest tube remains below the chest level at all times to maintain a seal. When the patient inhales, air and fluid from the intrapleural space are drawn into the drainage tube and emptied into chamber 1. Because the fluid in the drainage chamber is heavier than the air, it cannot be drawn back into the tube on inspiration, nor can air from the atmosphere enter because of the water seal. Additional chambers, also with water seals, are needed for drainage from the patient's pleural cavity and for suction regulation. Chamber 3 on this figure is used if suction is also attached to the patient's tube. Central venous catheters are increasingly used for patients who need long-term medication, frequent blood transfusion, hyperosmolar solutions, or total parenteral nutrition, TPN. When a patient cannot get enough nutrition through the digestive system, doctors may prescribe intravenous partial or total nutrition. Partial parenteral nutrition is given through a large gauge catheter in a peripheral vein and provides a combination of lipid emulsion and amino acids, often with added vitamins and minerals. Central venous catheters are also used to measure central venous pressure and must be accurately positioned in the brachiocephalic vein at the junction of the superior vena cava or within the superior vena cava itself. Proper placement is confirmed with X-rays or fluoroscopy, with the catheter ideally visible just medial to the first rib at anterior border. Tunneled catheters are inserted through the skin and tunneled under it to a central vein, making them suitable for long-term use and less prone to infection. Non-tunneled catheters are inserted directly into a central vein without a tunnel, making them ideal for short-term use, but more susceptible to infections. A PICC line is something that you will commonly have to image or come across seeing a patient have one inserted. PICC is an abbreviation for peripherally inserted central catheter, and they are usually inserted in a vein in the arm and enter at the junction of the right atrium and superior vena cava, and they're used for extended intravenous therapy. It is used for medication administration as well as nutrient delivery and is less invasive than central line usage. An implanted port or port-a-cath is used for patients needing long-term intravenous medications or transfusions. It consists of a small device implanted under the skin, usually in the chest, which connects to a catheter in a central vein. The port allows for easy administration of fluids, blood, and chemotherapy, as well as taking blood samples. It remains in place for years, requiring less frequent needle insertions compared to the use of a PICC line, and should be handled gently to avoid applying any type of pressure to the area. When caring for a patient with a central venous catheter or port, it is crucial to prevent infection at the insertion site. Always get a physician's order before removing or changing the dressing, and use medical aseptic technique and wear a mask if the dressing is on the upper thoracic region to avoid contaminating the area. Implanted cardiac devices include pacemakers, as shown on this radiographic image, as well as implanted cardioverter defibrillators. Pacemakers regulate irregular heart rhythms with electrical pulses delivered through leads, while newer models may not require leads. ICDs, similar to pacemakers, monitor heart rhythms and deliver shock to correct abnormal rhythms, also functioning as a pacemaker if needed. The American Heart Association advises using ICDs only for life-threatening arrhythmias, and other treatments have failed. Tissue drains are used at wound or operative sites to manage large amounts of drainage, commonly used in orthopedic and abdominal surgeries. While surgeons still use them to remove fluid and air, others are moving away from their use, especially after uncomplicated surgeries like total joint replacements. Research suggests that drains after laparoscopic procedures may increase wound infection rates and delay hospital discharge. During patient assessment, it's crucial to identify all drains and ensure no tension is applied that could dislodge them. Infection control is also important, as tissue drains create an opening that can easily become infected. When imaging a patient with a drain, use surgical aseptic techniques if touching the area to prevent introducing new microorganisms into the wound. A Penrose tissue drain uses a soft rubber tube resembling a tourniquet that allows drainage to flow freely out of the tube. These are typically used for superficial wounds or abscess drainages. A Jackson Pratt tissue drain uses a small bulb to create constant low pressure as well as suction, collecting drainage of fluids into the bulb. This is often used after abdominal surgery. A Hemovac style tissue drain utilizes constant low pressure to expand an accordion style container as it suctions out fluid. These are commonly seen after hip replacement surgeries. A Constavac made by Stryker is a drainage and blood conservation system that allows for the reinfusion of blood back into the body without disconnecting the system. Typically, these are used in total joint replacement surgeries. A UTI, or urinary tract infection, is the most common nosocomial infection due to non-sterile techniques of catheter insertion within hospitals. Nosocomial refers to infections or conditions that are acquired in a hospital or a healthcare setting. A straight catheter is used for draining the bladder or inserting liquid and then removed. An indwelling catheter has a cuff on the end that holds it in place for long periods of time. While a patient with a catheter is in the department, you always want to keep the bag that collects the urine below the level of the bladder and do not allow urine to drain back into the bladder. Never disconnect the drainage bag and clamp, as well as the tubing, and do not drain the urine unless told to do so by the patient's nurse or physician. Oftentimes, patients that have catheters, their urine output is being measured, so you do not want to disrupt the measurements of the urine if you empty the bag without being told to do so. When transporting a patient with an indwelling urinary catheter to the diagnostic imaging department, the drainage bag should be kept below the level of the bladder to ensure proper gravity and flow and prevent backflow, which could cause a urinary tract infection. The tubing should be coiled over the patient's leg and not below hip level to avoid obstruction. If the bag needs to be lifted, clamp the tubing to prevent any type of backflow. For patients in a wheelchair, you want to attach the drainage bag to the underside of the chair, ensuring that the tubing is coiled at the level of the hip and does not touch the floor or become tangled within the wheels. The bag should never be placed on the patient's lap or abdomen to avoid urine reflux into the bladder. You always want to avoid disconnecting the catheter from its closed drainage system to prevent infections. If disconnection does occur accidentally, a new catheter and drainage system must be used. Technologists should not disconnect the catheter or empty the bag without being told to do so, and should consult with a nurse for guidance on monitoring urine output for laboratory testing. There are two main methods of managing urinary drainage: the suprapubic catheter and the condom catheter. The suprapubic catheter is inserted directly into the bladder through an abdominal incision, often used after surgeries for chronic incontinence. It is attached to a closed drainage system and must be handled with care to avoid tension and maintain aseptic conditions. The condom catheter is an external device for male patients who are incontinent or have conditions that cause spontaneous bladder emptying. It is a soft rubber sheath secured to an adhesive and connected to the drainage tube as well as the bag. This catheter should be changed every 24 to 48 hours to minimize risk of UTIs. When dealing with patients with either type of catheter, radiographers must be cautious not to dislodge or damage the catheter and must respect cultural differences and beliefs related to catheterization procedures. Retrograde pylography is a radiographic technique used to visualize the proximal ureters and kidneys by injecting iodinated contrast through a catheter inserted into the ureter from the bladder. This is typically performed in a cystoscopy suite under guidance from a urologist. The procedure helps assess ureteral obstructions caused by strictures, tumors, or stones, but does not evaluate renal function and usually involves imaging one side at a time, though both kidneys may be studied if needed. If a patient has an obstructed ureter due to a stricture, edema, or tumor, a stent made of soft, pliable silicone may be temporarily or permanently inserted to relieve the blockage, either surgically or during a retrograde pyelogram. Complications from having a stent can include infection and obstruction from incrustation or clot formation, with the technologists handling imaging while the physician and nurse manage patient care and instructions. And the patient typically recovers under general anesthesia in a recovery suite. This image is an example of a double pigtail of a stent that is visible in the renal pelvis of the patient's right kidney, with the distal end curled in position within the bladder, identified by both of the arrows. A stoma is an artificial opening created on the abdomen for bowel elimination when the lower GI tract is damaged or diseased. The type of stoma is named based on the part of the bowel used. A colostomy involves the colon, while an ileostomy involves the ileum. Stomas may have one or two openings. The proximal stoma releases fecal matter, while the distal stoma emits mucus. Patients with ostomies often experience significant emotional and psychological adjustments and may require careful, empathetic care, including managing the stoma dressing and pouch. Patients with a colostomy or ileostomy undergoing a GI barium study should receive specific pre- and post-procedural instructions from the radiologist as well as the physician. They should also bring an extra pouch with them to cover their ostomy to ensure they are prepared for the procedure. This image is just a representation of the different areas of the colon and what portion needs to be resected depending on the type of ostomy a patient may have. These images represent what a patient with a ostomy bag will look like. So the ostomy bag will cover the area of the stoma. The stoma is the image on the right. So that's pretty much just showing where the surgical area is, and then the bag connects to that stoma, and then the fecal matter is collected into the bag. Patients are responsible for changing their own bag as well as maintaining proper stoma care. If patients are in a hospital, they may require the help of a nurse or a medical assistant to help them with the changing of the bag. In conclusion, in the radiology department, you are going to come across a variety of different types of tubes, lines, and drains. It's important to be able to identify each as well as what their accurate placement should be and know how to handle them with care. NG tubes are inserted into the stomach, and NE tubes are allowed to travel into the small intestine, so they go a little bit further. Gastrostomy tubes are surgically inserted directly into the stomach. ET tubes are inserted into the trachea through the mouth when a patient is unable to breathe on their own. Tracheostomies are openings in the trachea to relieve respiratory distress. Patients with tracheostomies may require suction. It is important that radiographers know that they do not perform the suction, however, they can assist and should be able to identify where all the equipment is within the exam room or imaging department. Mechanical ventilators are used to support respiratory function. It's important that you handle them with care, and they should never be disconnected from the power source. Imaging patients on ventilators can be a challenge, and you may require the assistance from the nurse when imaging a patient in their room. Typically, these patients are imaged using mobile radiography in the ICU, which is the intensive care unit. Chest tubes may be connected to a water-sealed drainage system. It's important to know the use of the chest tubes, where they should be located, and also the treatment of the drainage system itself. You should never lift them higher than the level of the chest to avoid dislodgement or mixing of the fluid and the air. Venous catheters may be kept in place for long periods of time to deliver nutrition, chemotherapy, as well as medications. Radiographers must learn the different types of tubes and their location in order to provide quality radiographic images when verifying the location of these lines. Tissue drains may be used in patients post-surgery to remove fluid and blood from the area. It's important to never allow tension to be placed on the drain because it might cause dislodgement. Urinary catheters such as Foley, suprapubic, or the external catheters should never be removed, and it's important when transporting a patient with a urinary collection system never to raise the bag higher than the level of the bladder. This can cause flow of urine back into the bladder, which can leave patients susceptible for infection. Lastly, ostomies are opening within the large bowel. These are called stomas. Patients who have an ostomy have undergone an extensive bowel surgery. So the fecal matter is being outputted into a bag through the stoma. It's important to handle the bags with care and treat patients kindly. Patients with ostomies and stomas tend to be very self-conscious.